Hi all, my name is Professor Dragonich. I'm from the School of Public Health and Preventive Medicine, and welcome to this short video presentation in which we'll cover some of the key biases associated with screening. So here, as always, are our objectives as they relate, in this instance, to Module 1. So after this module, hopefully you should be able to define screening, understand the benefits and risks associated with screening. So we covered that in the previous video. And in this particular video, we're going to focus on the implications of a couple of key biases associated with screening and particularly screening programs. So the first bias that we want to discuss is screening bias. So screening bias really is another form of selection bias in the sense that it relates to participants that we recruit to our screening programs. So I guess one thing that's inherent with all screening programs is that participants, generally speaking, who volunteer for these types of screening programs, and you can think of the colorectal cancer, so the government-sponsored FOBT program here in Australia is a really good example of this. Participants in those programs tend to be healthier than those who don't volunteer or who don't comply, and there's a variety of studies that you look at a number of screening programs that when they break it down to those that attend screening, those who comply as opposed to those that don't comply, you really see this sort of healthy volunteer cohort effect. Obviously, this will have an impact upon disease-specific and overall mortality. So, whether it's a good thing or a bad thing, it's something that we need to keep in mind in terms of looking at the not so much the efficacy, but more so the effectiveness of the screening program. So, two major biases that I want to cover in this short video. The first being length time bias, which we'll discuss now. So, length time bias basically occurs due to the heterogeneity of the disease, in the sense that for a lot of these tests, it's really difficult when it comes to particularly screening for cancer to differentiate between fast and slow growing tumours. So the problem with length time bias with respect to screening programs for cancer is that screening programs, just by their very nature, are more likely to find slow growing tumours. So if you think about the previous example of your screening for cervical cancer, screening every 5 years, if you've got a very slow growing tumour, that 5-year interval is going to be sufficient. And so you're picking it up at an early stage, one that probably, well, you can't say probably, but may not have become aggressive down the track, so you're providing a better prognosis. So really the issue that we find with length time bias is that we get this overrepresentation of slow or slowly progressing disease amongst the population that's been screened. So here's just a graphical representation of length time bias. So on the x-axis we've got time, on the y-axis we've got stage of tumour, so slow, or I shouldn't say so, slow, so non-severe, if that's a word, stage, or a early stage of the tumour, as opposed to an advanced stage up here. And so obviously, if we're screening at this point in time, these slow growing cancers will be able to be picked up by the screening, as opposed to these rapid growing cancers, which at this point in time won't be picked up with our screening protocol. Hence why we've got this length time bias of only really picking up those slow growing cancers. Again, if we wanted to, we could decrease the interval between screening rounds, but again, that increases the risk of overdiagnosis. So the second bias that we wanted to discuss is lead time bias. So lead time bias again makes a screening program look potentially better than what it is. And the way it does that is because it doesn't take into account the natural history of the disease. We'll provide an example here. So here we've got the natural history of a particular cancer. So let's say, hypothetically speaking, there's the onset followed by a 4-year asymptomatic period, in which case there would be some sort of clinical presentation, after which it may be a 3-year illness, at which point in time death occurs. So the natural history of the cancer is 7 years. So in an unscreened population, we don't take into account this history in terms of preclinical presentations. We just get the clinical presentation, we get the 3 years, and then we get the death. So it seems like the time from diagnosis until death is 3 years. Compare that to the screened population, where we may be having an example of 2 years, at which point in time there is some sort of screening is detected, so we bypass this sort of clinical symptom stage, and then similarly there's 3 years of clinical illness, and so we end up getting a time from diagnosis being 5 years. So what it appears is, when you compare the screen population of having basically a de facto survival time of 5 years, as opposed to the unscreened population of having a de facto survival rate of 3 years, it seems that screening is more beneficial because it takes, or it provides you with an extra 2 years worth of life, which we know is not true because it doesn't take into account the natural history of the illness beforehand. So I'm not going to spend a whole lot of time in terms of the measures of screening effectiveness, only to highlight that there are a number of measures that can be used to quantify how effective a particular screening program is. So we can use our standard relative risk reduction, odds ratios, absolute risk reduction or increase, etc. But what we can also include are such things as DALYs and qualities, so quality adjusted life years and disability adjusted life years. So gains in life expectancy, cost, so cost per case detected, cost per life saved, but also, I guess from a screening point of view, number need to screen. So we obviously know about number need to treat. That relates to how many people need to be treated with that particular intervention in order to prevent one additional death. Similar process for screening. We have number need to screen. So how many people do we need to screen in order to prevent one additional death? So hopefully you found that video somewhat useful. As always, feel free to contact me on the email. Otherwise, all the best. Thank you.